So again, good afternoon. We are gonna finish up cardiomyopathy by looking at arrhythmogenic right ventricular cardiomyopathy or ARVC. And then I think we have non-compaction. Again, arrhythmogenic right ventricular cardiomyopathy, not very common, very testable. As a matter of fact, not very testable. It appears in all exams. And what it is fibrofatty replacement of the right the right ventricular myocardium. As you recall, the functions of the heart is to pump, and you need muscle. Is the muscle which contract and relax, which brings about the pumping function of the ventricles. Okay, so when you have arrhythmogenic right ventricular cardiomyopathy, the muscle is replaced by fibrofatty tissue. It is thought to be a genetic defect of desmosomes, which are proteins which link the muscles, the heart muscles. Okay. The incidence is about 1 in 10,000 individuals in the United States. So again, not very common. However, it causes a lot of sudden cardiac death, especially in young individuals. So if you take all comers, young individuals with sudden cardiac death, then the incidence of arrhythmogenic right ventricular cardiomyopathy will increase. All right, so it's going to represent a significant proportion of young individuals with sudden cardiac death. How do you recognize it? Okay, so even before you take the patient to the echo lab, there are certain clinical features which will sort of tip you off that you're dealing with ARVC. So when you look at your ECG, one of the first things that you'll see is what we call the epsilon wave. But again, before you get to that, when you look in the anterior leads, which is V1 through V3, you'll get T-wave inversion. So the T-wave will be inverted in leads V1, V2, and V3. And then you're going to see what we call epsilon wave in about 50% of these patients. And it is described as terminal notching in the QRS. So we'll show you examples of that. You tend to get a lot of premature PVCs, and some of these patients will present with ventricular tachycardia with a left bundle branch block morphology, because the problem is with the right ventricle. So the ECG will have a left bundle branch block morphology when the patient presents with ventricular tachycardia. The mode of death, sudden cardiac death in these young individuals is usually ventricular tachycardia and ventricular fibrillation. Okay, so again, tip off. And I like this in exams. I know, it's echo exam, but the ECG feature is very interesting. So you'll get it. T-wave inversions in leads V1 through V3, terminal notch in the QRS, and so-called epsilon wave. And then the tachycardia will have a left bundle branch block morphology. So these are what we call the terminal notching in the QRS. So towards the end of the QRS, you have these so-called notches. So that's the epsilon wave. So if you have a young individual with frequent PVCs, probably ventricular tachycardia, and a left bundle branch block morphology in the ECG, and you see these terminal so-called epsilon wave, then it's suggestive. All right. So again, the pathology is when you look in the right ventricle, you'll get fibrofatty infiltration. So your echo the RV muscles, or where the RV muscle is supposed to be, you're going to see these white infiltrates, which is fat. Okay, so you look in so this is your parasternal long axis view. Your RV is right up here. You're going to get RV dilatation. When you look at the RV muscle, it's going to be white. Okay, not your normal myocardial consistency. And the RV is going to be dilated, and the RV systolic function is going to be depressed. So your TAPSE is going to be reduced. Your RVS prime is also going to be reduced. Okay? So again, on your two-dimensional echo, you're going to get increase in the RV size. So increase in the right ventricular outflow tract. Remember how you measure that. So if you're going to measure it at the mid-level, anything greater than 3.3. If you're going to measure the RV at the right ventricular outflow tract, distal, anything greater than 2.7. So you have to remember your measurements, okay? All right, and again, you're going to get abnormal RV systolic function. Your TAPSE is going to be reduced. Your RVS prime is going to be reduced. Any other method that you use to evaluate RV systolic function is going to be abnormal. You can also get regional wall motion abnormalities. So you can look at the apex and the anterior wall. And the moderator band, which is in the RV, is going to be hyperreflective. So young individual, the ECG features and then the echo features should clinch the diagnosis. So again, your RV systolic pressure is usually low because the RV pump is malfunctioning. The RV pump cannot generate a large RV pressure. So, you expect, because the RV is not contracting well, the pressure to be elevated, but the pump is very abnormal. So the RV systolic pressure is going to be reduced. And it is not unusual to see TR velocity less than 2 meters per second. So when you calculate your TR gradient 4V squared, it's going to be reduced. All right. So that is arrhythmogenic right ventricular cardiomyopathy, or some literature may call it arrhythmogenic right ventricular dysplasia. So that is the fibrofatty infiltration of the myocardial muscle. Okay, it's usually the RV. The importance of it is that these patients will present with sudden cardiac death, ventricular arrhythmia, ventricular tachycardia, ventricular fibrillation. So, and then when you look at your ECG, you'll get T-wave inversion in the anterior septal leads, V1, V2, V3. You get your so-called epsilon, which is terminal notch in the QRS. If the patient presents with ventricular tachycardia, then it's of the left bundle branch block variety. All right, ARVD or ARVC. Now we're going to come to non-compaction cardiomyopathy. This is a developmental problem, okay? So this is essentially a congenital problem. So this is a problem that one is born with, okay? These patients tend to have marked trabeculation and deep intratrabecular recesses in the endocardium. So the endocardium look very spongy. Once you see one case, you'll never forget it. Okay? So marked trabeculation and deep intratrabecular recesses in the endocardium. It results from failure of the myocardium to develop during embryogenesis. During the developing fetus, the myocardium did not develop properly. So you have these trabeculations, very prominent trabeculations. And when you do your color flow Doppler, you can see the color going into these trabeculation, telling you that it is real. And at present, they would recommend that you use contrast. So when you use microbubble contrast, it clinches the diagnosis. Okay? So non-compaction, not very common. It's one of the causes for a dilated cardiomyopathy or heart failure with reduced ejection fraction, but it's classic. It's a classic condition. Again, administration of contrast to show the trabeculation clinches the diagnosis all the time. So the classic definition again is when the ratio of the non-compacted, that is where you have the trabeculation, to the compacted layer without the trabeculation, if it's greater than 2. So the ratio of the non-compacted to the compacted layer is greater than 2. Okay? So that's one of the definition. The LV tends to be dilated since it's not contracting properly, and the LV systolic function is also depressed. Okay, so it looks something like this. So this is a 4-chamber. This is another 4-chamber, but I don't know if you can see it. You can see these deep trabeculations, okay? And then when you look, the LV systolic function is depressed. If you give contrast, it goes straight into the crevices, into the trabeculation, and you get a much better picture. LV systolic function is depressed. LV is dilated, and you get these deep trabeculations. Okay, so this is a parasternal long axis view. You can see these trabeculation right there. You can see them. Okay, LV is dilated, but it's a classic presentation. It is one of the cause of dilated cardiomyopathy or heart failure with reduced ejection fraction. So all right. So when we go over cases, we'll show more of these, and we will show you what the contrast evaluation of non-compaction looks like. But your ARVD or ARVC, arrhythmogenic right ventricular cardiomyopathy, and your non-compaction is very important for exams. Okay, you have to know it. So go over it. When we do our webinar, we will look at more cases so you become more familiar with it. So you're going to get it in exams. You're going to get it in an exam, and you should be able to identify it. Okay? So this concludes cardiomyopathy.